Okay, this video is to address the quiz questions that I've gotten some questions about, and I told you to ask me questions if you needed to. Um, there were several, since it's only a 25 question quiz, I'm just going to go over the whole quiz and let you know. The quiz itself was supposed to give you my rationale for what an incorrect answer was, and for whatever reason it did not, so I'm going to go through all of that with you. Um, okay, let's see here. I don't know that these will be in the same order as what you got because I always set the quiz to be a different. I mean, it randomizes the questions whenever somebody takes it. So, all right, the first question is: Patient B was started on amiodarone for atrial fibrillation during a recent hospitalization. He now presents to your office with complaints of abdominal pain and nausea without vomiting. I didn't put a G on that. Which of the following should be included in the laboratory test that you obtained during the visit? And the answers were digoxin level, liver function, iodine, amiodarone level. So it's not digoxin level because the patient's not on digoxin. We're talking about amiodarone. It's not an iodine level or an amiodarone level. Those two aren't even possible. So what we talked about in the book and on the lecture was um, liver function panel because amiodarone can potentially be hepatotoxic. And I have on my answer, it says amiodarone can potentially be hepatotoxic. Always monitor liver function while on this drug, and especially with specific complaints such as abdominal pain and nausea. See page 96 for adverse reactions. The next question, which I have marked as question 2, antiarrhythmic drugs typically do not induce other arrhythmias. This is a true false, and of course the answer is false. The main side effect of any antiarrhythmic drug is the potentiation of another arrhythmia. Um, Question 3, the calcium channel, also known as diltiazem, is useful for treating the arrhythmia known as atrial fibrillation. The calcium channel blocker Norvasc, also known as amlodipine, is useful for the treatment of hypertension. Patient R has both conditions, hypertension and atrial fibrillation. Patients who are taking these medications should be educated to watch for which of the following. Um, okay, and the answers are angioedema, thyrotoxicosis, heart failure symptoms, and worsening atrial fibrillation. Okay, angioedema is incorrect. That's more common with ACE inhibitors or ARBs. Thyrotoxicosis, no, because neither of these affect the thyroid. Heart failure symptoms is the correct because calcium channel blockers can cause worsening heart failure or heart failure like symptoms such as peripheral swelling. And then worsening atrial fibrillation, probably not, because this is actually for the treatment of atrial fibrillation. Okay. Um, Question 4. Patient R presents to your office with complaints of palpitations. Vital signs show that his blood pressure is 160 over 88 and his heart rate is 112. And electrocardiogram shows this is simply a sinus tachycardia with no other abnormalities. So blood pressure 160 over 88 and sinus tachycardia of 112. Upon reviewing his chart, you find that his systolic blood pressure was greater than 140 the past 2 visits, and his heart rate is typically in the 90s. Which of the following medications would be best to first prescribe? Now, this question I will look back through because the answers are lisinopril slash hydrochlorothiazide, hydralazine, losartan, and metoprolol. My answer is metoprolol, and my reason for that is because that's one drug that will treat both symptoms, hypertension and the man's tachycardia. Losartan will only treat the hypertension. Um, Hydralazine will only treat hypertension, and it can cause rebound tachycardia. Lisinopril hydrochlorothiazide does not treat the tachycardia; it treats the blood pressure. But I also know that in the book, and I have probably said as well, the guidelines say that hydrochlorothiazide is the first line treatment for treating hypertension. I strongly disagree with that in my own practice, but for boards questions and for your education, that is actually true. So if I'll look through, if you answered the lisinopril/hydrochlorothiazide, that answer is also acceptable. But for our clinical reasoning and treating the patient, if there's one drug that can treat both of these problems, that's what my rationale for the answer metoprolol was. So just remember that for boards, hydrochlorothiazide is the first line treatment for hypertension, but in this hypothetical question, metoprolol will treat tachycardia and hypertension. All right. Whoops. Oh, man. Hold on a second. I just made the test go away, and I'm not sure. No, there it is. Okay. Number 5. Which of the following combinations of drug therapies would best benefit a 75-year-old man with CHF with an ejection fraction of 35%? Okay. I'll start at the very bottom because answer number 1 is the correct answer. So the last answer is an ARB, hydrochlorothiazide, and beta blocker. An ARB or an ACE inhibitor is always good for ejection fraction of 35% or less. Beta blocker, definitely. But hydrochlorothiazide is not a cool diuretic for somebody with heart failure. We need a loop diuretic, so that one's wrong. All right, the next one is beta blocker, diuretic, and digoxin. That is a mostly correct answer, but not really. Beta blocker, yes. Diuretic, even though I did not say what kind. And digoxin does help with contractility, but the ejection fraction is the main thing here. You must have an ACE inhibitor, if not contraindicated. The next one is ACE inhibitor, diuretic, and calcium channel blocker. This is systolic dysfunction because his ejection fraction is low, so a calcium channel blocker would make the heart failure worse, so that's incorrect. So, question, ACE inhibitor, beta blocker, and diuretic, that's the answer. The rationale is ACE inhibitor helps with left ventricular remodeling. Beta blocker decreases heart workload and increases contractility, and the diuretic, and in his case, it would be Lasix, torsemide, Bumex, spironolactone, but not hydrochlorothiazide. So that's my rationale for that answer. I'll look through. I'll tell you what, if anybody... No, I can't. Never mind. That's my answer stands on that one. Question number 6. Patient G was recently discharged from Big City Hospital. While there, he was diagnosed with a myocardial infarction and received a stent to one of his coronary arteries. You have followed his progress in primary care follow-up. 6 months later, he has continued chest pain that is consistent with stable angina. And in parentheses, I put, assume your tests and diagnostics show no evidence for an acute infarct, and you intend to have the patient follow up with his cardiologist anyways. Which of the following drugs would best benefit this stable patient? So I put Coreg, which is a beta blocker. It's good for contractility with heart failure patients. Probably not going to do much for angina. Lisinopril works for hypertension and remodeling and heart failure. Not going to help. Cardizem, that is a calcium channel blocker, which we typically use for treatment of arrhythmias. But then Ranexa, that is a modified long-acting nitrate, such as it is very closely related to Imdur. That is the correct answer in trying to treat stable angina in a patient with coronary disease. Now remember in these questions, if I don't mention another symptom or disease process, then you assume that the only thing we're dealing with is this one disease process, okay? And at the bottom I put see page 99. Ranexa is a long-acting anti-anginal that will not disrupt acute attacks, but is useful for the treatment of stable angina. Okay, number 7, a patient presents to your office for a follow-up regarding some recent laboratory work. The patient has at least 3 consecutive office visit blood pressures with a systolic pressure greater than 140. The specific lab work you are discussing today is a hemoglobin A1C, which is elevated and indicates that the patient's diabetic. So far we've got hypertension, and diabetes. Okay, the diabetes is a new diagnosis. Among the drugs you will prescribe to treat his hyperglycemia, which of the following would be beneficial? This question is actually tricky. As I read it myself, I'm thinking, what in the world did I put this answer on here for? Um, the answer I put is correct is lisinopril, and I know the reason for it because lisinopril is a good option for blood pressure and to help protect kidneys in the case of diabetes. Propranolol obviously was not a good choice. That only treats blood pressure. Aldactone has absolutely nothing to do with this. And the other answer was Lantus insulin, and that would not be correct, of course, because this is a new diagnosis. Diabetes is type one. We know that, I mean type two. So an oral anti-diabetic would be better. Remember the drugs you would prescribe to treat his hyperglycemia. If I said hypertension, that would be correct, and I think that's what I meant to say. So everybody's going to get credit on number 7, whether you pick lisinopril or not, because that's just not a good question, and I will modify that. And that question was on the list of people that things asked about, so you're not crazy. I am. But if you are treating hypertension in hyperglycemia, an ACE inhibitor is good if there's no renal failure. Question number 8, the usual first-line treatment for hypertension, if not otherwise indicated, would be lisinopril. This is a true/false. The answer is false. And this is a textbook, board's question. The first-line treatment is usually hydrochlorothiazide.